Well, I'm Atwine Daniel. I'm a Ugandan medical doctor by background, and I'm an epidemiologist with a 14-year experience in clinical trials in infectious diseases in low resource settings. I've worked with the MSF Epicenter, that's Doctors Without Boundaries, in different capacities over the years, starting from being a clinical trial doctor, a principal investigator, to coordinating the overall TB research, and also clinical trial training programs within the partnership of Epicenter and Mbara University of Science and Technology. I'm also been past-timing as a lecturer and visiting lecturer with Mbara University of Science and Technology for the last 12 years. I'm a co-founder and CEO of a private research organization called SOA Research Foundation, which focuses on research excellence promotion and through quality research implementation, research consultancy, and skills development. I'm currently a senior global health scholar in residence at the University of North Carolina, looking at issues related with decolonization of global health research. And today I'll be talking to us about fairness in global health research partnerships. And before I continue, I would want to really extend my gratitude to the residence sponsors, those who have supported my residence here at University of North Carolina. That's the College of Arts and Sciences under the African Studies Center and the Institute of Global Health and Infectious Diseases. Special thanks to Dr. Ross Boyce and Ada, who have organized my visit here from the start, but also to the entire community of African Studies Center and the General University of North Carolina at Chapel Hill for the wonderful hospitality and experience I've had here. So the purpose of this lecture is to stimulate reflection and discussion towards improving fairness in research collaborations as a key aspect in global health decolonization. We will look at a number of things in this lecture, starting with contextualizing research partnerships in global health, and we'll ask ourselves, does unfairness actually exist in global health research? And we'll discuss through an example of unfairness in global health research and what perhaps we need to desist and what we need to promote. And we'll discuss also steps towards fairness and the way forward on addressing unfairness in global health research. So starting with research partnership in the context of global health, what we are used to and what we see is that these partnerships can be what we call South-to-South partnerships, where low-income countries are partnering with other low-income countries. So in the context of Africa, these are partnerships between two African countries. And then north to north, also we know there's that kind of partnership where the high-income countries are also partnering with high-income countries. But one which I missed right here is actually north to south research partnerships. And maybe those are ones I'll talk more about today, north to south. These are essential in delivering research and innovation for global health and partners development. We definitely know that at the basis, at the core of global health, lies partnerships between, those who are more equipped with those who are perhaps less equipped, and it's supposed to be a mutual relationship, which is equitable and which, you know, is fair and which can cause mutual benefits. Partnerships are at the heart of research excellence and innovation, and fairness is always key, and it's a mutual responsibility of both partners. So whether we're having a partnership of a high-income country investigator and a low-income country investigator, we expect that there will be fairness in that kind of partnership, and which is really essential for sustaining such partnerships, but also for maximizing their benefits and outputs on both sides. Unfairness it can affect partners themselves, but also it can affect the research participants, the community where the study is done, the institutions which are involved, but also the countries which are involved at a big scale. So just for someone to understand their uniquenesses, really, and also complexities in research partnerships. These very uniquenesses can actually form the complexity that we'll be talking about. Within, for example, a south to north partnership, or a partnership between a low-income country investigator or institution with a high-income country investigator or partnership or institution, let's say, what we normally see is that there are different disciplines. You find that at times partnerships entails people from different disciplines working together towards a common goal. At times, what we experience is that these are two people from different research settings, and at times there are different policies that govern how research should be done, you know, in different institutions which are partnering. And at times it's different geographical locations, and definitely that too has a bearing on how the partnership runs. Also, in such partnerships, there's different power dynamics, but also vulnerabilities. So what we see is that, you know, you may find that one of the partners was more instrumental in generating or attracting the funding. And because one has the funding, they might feel like they are at a different, they have a different right on what goes on in a partnership more than the other. So we can't fail to envision this kind of imbalance and differences, which altogether can really result in unfairness or some very unique challenges that happen in research collaborations. Another aspect which is important is the different exposures or experiences. So an investigator in a high-income country at times may be more exposed to how things are done as compared to the low-income country investigator who may not have had sufficient experience on how to even implement a good collaboration that benefits them. So this is a kind of context that we see in global health research collaborations, and all these can increase the probability of untoward issues in research collaboration. The challenge to collaborators is to determine an appropriate response to such issues that may arise during any stage of collaboration, because they can happen at all stages of the collaboration. Some of the stages of research collaboration where we have to be keen to make sure that there is a balance or that there is equity or fairness It starts with a conceptualization, and these are the stages of research collaboration. At the point of conceptualization of a project, it's going to engage two partners, and that includes proposal preparation and submission, management. So at that point, it's important that we ensure that there is fairness, there's a balance, as we shall see. But unfairness can occur at any of these steps: at conceptualizations, at implementation of the project, at evaluation of the project, and also during dissemination. So that brings us to a question: does unfairness exist in global health research? And that's why we're talking about this, because many people may not actually recognize that there is unfairness until when you think about certain things. So does it exist? Now, in this, we will start with, talking about Africa, the status in Africa. Does Africa benefit from, for example, clinical trials conducted in Africa? And well, they can be clinical trials or any other kind of research. Does Africa benefit from the research that is done or implemented within Africa? What do we see normally, should we say that Africa benefits through employment? You could say yes, partly. Should we say that there is local capacity building? It could be yes or no. Should we say that there is local infrastructure development that comes out of these kind of partnerships? What about publications and authorship? Is there fairness in that area? Or we find that much of the publications are inclined towards the high-income country investigator, and maybe positions of authorship, is there a balance right in there, depending on the effort and contribution made by two parties? Do we see fairness in international dissemination? Who becomes the face of a research partnership globally? Who presents the results? Who disseminates? Do we see improved healthcare following an implementation of a research? How do the local community benefit? And how long does that kind of improvement happen? And in this, we talk about, post-trial access. If someone has evaluated a good intervention in a community, how does the local community benefit after the end of that project? Or the results go to a high-income country and they are affected, but then the local community goes back to where it was before. So there are issues of post-trial access. You've tested a drug, and then you find it effective. How do the local communities in Africa benefit from that after the study? Recognition. If there are good outcomes of the study, who is recognized? Who owns the data? And all these are very pertinent issues now. Patent ownership, who owns the patent? Does the institution where the study is done benefit or have a share in patent, together with the high-income country institution or investigator? Future use of data, of site data. Do research sites in Africa have a strong ownership or hold of their own data or the data generated within their context? Can they use it freely as such data? Then what about the reputation and publicity for a low-income countryside? Does the income, I mean, does the site or the where the research is done, does it benefit in a similar publicity as compared to the institution of the high-income country investigator? So these are things we have to think about. And also budgeting, inconsiderate budgeting with no local input. So when budgets are being made for research projects, what is the engagement of the local implementers? So this is not a whole list, but it's something that can start us to think. And what you see there in that picture is normally what we seem to see, the sandwich phenomenon, where the Africa is sandwiched between two hands. So both front and outside, you're surrounded. And this kind of scenario can cause less acknowledgement of the engagement of one partner in a global health project. So as we look at this, all this give us an understanding of what kind of fairness or unfairness could happen in global health research. But then the question is, do high-income country researchers also experience unfairness in global health research partnerships? And that's the question. Just as we started from, I mean, just as I said at first, that unfairness affects both partners in a collaboration, although it can affect them differently. So when I look at what could happen, at least from my experience, to high-income country researchers who are partnering with low-income countries, the questions we have to ask ourselves is there transparency issues resulting in poor planning? Because failure for proper planning can still cause a project not to work properly and not to achieve its goals. Are there accountability issues? Are there non-compliance to the agreed procedures and protocols? Maybe there are sample losses or data losses. All this can impact on the project. Are there fraudulent recruitment processes of human resource? Are there fraudulent procurement processes? Are there unsupportive research regulators and ethics committees that are not supporting the project and maybe cause unnecessary delays? Are there inadequate coordination of research processes by low-income country researchers, resulting in delays in achieving the targets? There could also be non-compliance to ethical standards, that someone creates a lot of violations and that can hinder the validity of the project. Is there concealment of vital information? Is there hiding, and concealment of vital information that is important for both partners? Is there data falsification? And this really can be dangerous. Data falsification and manipulation. Is there overcharging of services or excessive expectations? So all this can result in also a sense of unfairness to a high-income country researcher investigator within the global health context. And this is why we need to look at fairness in such partnership, in a more balanced way. Now, as an example of unfairness in global health research and what we need to desist and what to promote, I will reflect on a recent paper by Bishar et al., which really talked about the challenges of globalization of cancer drug trials, recruitment in low middle income countries. And from this paper, we will be able to discuss a few things that, you know, they point on and which could help us to really appreciate what we need to avoid in research partnerships if we are to attain our goals of global health research. Now, there are issues of parasitism and parachutism in global health research that were reported in this paper. And what was noted is that there's an increasing clinical trials that are being conducted in Africa. But the problem with that is that there are also concerns about research parasitism and parachutism, which we'll talk about quite shortly. And we see that these similar concerns have been responsible for the resistance in COVID-19 vaccine trials, where people feel that why do a clinical trial in Africa where there are few patients of COVID-19, yet there are many patients in the United States, there are many patients in Europe who are suffering, you know, the most. So a bit of those kind of issues, if they are not addressed, and if the population feels this unfairness, it can cause this hesitance to future trials. Now, some of the commonly cited motivations for really conducting clinical trials, for example, in Africa, is the reduced complexity. Yeah, the process of approval is not as very demanding like in a high-income country. The cost of implementing the study is a bit low because of the low standard of living, and the possibility of running a trial with a substandard control arm in a low-income country context is very high. And just as we know that the standard of care, many studies compare an intervention with the standard of care in low-income country. And normally the standard of care in low-income country is at times outdated. It's not even compared to what is recommended in the high-income countries. And certainly that gives you a good opportunity to say this is better than what is happening. And also the ease of recruitment. It's easy to recruit because most people are vulnerable. They are poor, they are desperate to get care, and certainly they will be willing to participate in a study which can give them care and maybe compensate them. But also another motivation, at least with cancer trials, has been, you know, for getting drugs to be approved in high-income countries. So with such motivation, we have to think about what we need to desist in such partnerships. And we need to desist research parasitism in clinical trials. As we know, the Helsinki Declaration states that control arms, if someone is to test two interventions, the control arm or the comparative arm should receive, the people in there should receive the best proven intervention and not the standard of care in the local research setting. But this is not what we see. In most settings, investigators are using the standard of care, which is outdated, within the local context of the low-income countries. And they disguise, there's a lot of disguising that there's local inaccessibility of the global standard of care. And we can't get it. So since we can't get it, so let's use what is available. And studies that would not meet ethical standards or nor be able to recruit participants in high-income countries are able to be done in low, middle-income countries. And this is really, really quite unfair. It shows a certain level of unfairness, you know. And the consequences of all this is that that particular intervention, what we call the Me Too drugs or Me Too interventions, they are finally gain approval for use in high-income countries without conducting proper rigorous clinical trials against the real standard comparator in high-income countries. And this perpetuates an exploitative kind of form of research that enables unethical trials to be run in low middle-income country. And instead of improving fairness or equity, it discriminates, it causes discriminatory practice and inequality. So why do a research in low-income country, which is only going to benefit high-income countries? So that's the parasitism. And we also need to desist research parachutism. So most of the clinical trial outcomes rarely benefit the people of the countries where the research is done. And there is no post-trial access of most of the interventions that are evaluated. So these are things to think about as we promote fairness. So when you test on low middle income country populations, they should be able to benefit from that intervention and not just to benefit only the high-income country population. So these are some of the things that come up in all these discussions. And then there's desisting, capitalizing on vulnerability. So we know that most people are vulnerable in low middle income countries, but we must desist from capitalizing on that. Some clinical trials use that opportunity, you know, because it is easier to achieve the recruitment that you want. But most of the participation can end up being more of coercion, or coerced participation. And so thinking about this will help to create more voluntarism in consenting and in participation of such studies. So we also have to desist hijacking of local research priorities. So at times, conducting trials in low middle income countries to get drugs to be approved in high income countries without serving patients in the local community, it hijacks the local research priorities and agenda. So most times, instead of running research that the local investigators feel would benefit their population, they end up postponing it, but to run a research that has been proposed by a high-income country investigator, but which at the end of the day is not going to benefit the local population. And at the end of that project, people are back to zero, and they need to now see how to run what will help them, run a research that will help them. So we need to think about post-trial access. We need to think about focusing on low middle income country, people-centered or investigator-centered research. Then more support to locally initiated research projects that benefit directly the host communities, and also capacity building towards local investigator-initiated studies or trials. So another aspect that, if we are to ensure fairness, we need to promote equitable gains from global health research outputs. For example, when we look at the top countries that are leading in the world in scientific publications, we see China, United States, India, Japan, UK. But now when you look at all these, the question is, where are the low middle income countries, where the researches are done? Because these countries are greatly collaborative, and they collaborate with low-income countries. But how come there is less? It's difficult to see an African country within the first 50 countries with highest scientific productivity or publications. When you look at this graph, you're able to see that there is low representation of Africa in the top global publishing countries in science and technology. In the first 30 countries globally, only Egypt, which is 26th ranking. And that's it's a low middle income country, but mainly in North Africa and Middle East region. And then South Africa, which is 31st, and then Nigeria, the 50th, and Uganda is 83. So, but looking at that, if researchers, most of the research, is done in low-income countries or middle-income countries, we should be able to see more representation of low and middle-income countries in the publication, scoring. So there's a potential gap in sharing of outputs in global health research partnership within Africa and other low middle income countries, so which we need to look at. Now, there's also an aspect of supporting decolonization in access to scholarly materials and publication. There are quite some issues that I wanted to discuss here. The high-income countries' literature, for example, it fills the libraries of both high-income countries and low-income countries. When you go to the libraries, it's difficult to find literature by Africans and for Africans. There's paucity of information or literature about low-middle-income countries. And the question is it really true that there is no literature, or it is lost within the high-income country literature? So you find that much of what is known about Africa, what is happening in Africa, is written about by an high-income country scholar. And it is difficult to find African literature by Africans in the libraries in high-income countries, but also in the libraries in low-income countries. So there's also African journals. Most of them, some of them are not indexed in the international big databases that are trusted, that someone would trust in the high-income countries. So this discrepancy, it underestimates the contribution of low mid-income countries in the global health knowledge, and non-recognition of African partnerships in research outputs. So we talked about co-authorship and co-patenting. There should be a mutual acknowledgement, and high publication costs in high impact journals. These are very limiting, especially when it comes to investigators in Africa who have limited access to research resources. So how can someone publish in a journal which requires $5,000 US? That's almost an amount that can do a study, small study. Also, there are issues of limited research communication capacity in low-middle-income countries. So within the partnership, you find that most of the investigators in low-middle-income countries, some are not very well versed with scientific writing, and maybe they have writing phobia. But is there any conscious effort of building this, of building their capacity, or someone takes advantage of that? And also the funds of dissemination. So at times in such budgets of partnerships, much of the budget for publication is on the high-income country investigator. So you find that already there is unfairness at the budgeting level, and lack of conscious engagement of African researchers in research dissemination. So, for example, who becomes the face of any results that have come out of a partnership? So when you go to international conferences, you will find that it's the investigator and the income countries. So there's also a balance here that needs to be thought about if fairness is to be promoted. We also see limited capacity to conduct, desk research, basically like systematic reviews and meta-analysis. Most of the universities and researchers have limited access to international journals. Time is difficult to retrieve a paper, and there are costs, definitely large costs that are required to subscribe to these international libraries, and that even most institutions cannot really afford. So, and that creates a dependence on high-income countries. So we also need to balance that issue of access of scholarly material. Some of the steps towards fairness, definitely I wanted to really mention this. There's an initiative, a research fairness initiative, and which started really quite a while ago, but its first implementation in Africa was in 2017. And it gained acceptance. It has gained a lot of acceptance among many African countries. And the aim of this research fairness initiative is to improve global health equity and development by improving research partnerships, both local and globally. And they also they focus on making research collaboration more fair to increase trust, which is important, trust between partners, and to stimulate research and research management performance, both locally and globally. So what the Research Fairness Initiative has done, has developed a strategic management tool, and that tool is for research institutions, organizations, governments, businesses, to help them self-examine or examine their internal policies and practices to see if they are promoting fairness or if fairness is being implemented within their partnerships. And this is really the first kind of initiative that that has come up, that is really pushing this agenda of promoting fairness in global health research. So the problems that this research fairness initiative really seek to address, they address common problems in research partnerships. As I said, the uniqueness and the differences between partners can really create some problems, but also unequal opportunities to shape the research agenda, and unequal access to training and capacity building opportunities. So they look into addressing that. Unequal support for indirect costs and infrastructure costs, unequal credit and recognition for research contributions, and also unequal access to data and intellectual property, and unequal compensation for participation in research partnerships. So the benefits are not well shared. So, and every other kind of unfairness, just as we had talked about. So what normally the expectation of the Research Fairness Initiative is that if an institution is conducting research or it has been involved in partnership, they can self-assess themselves based on the 15 measures and conditions that promote fairness, which this initiative developed through a broad consultation. And when an organization submits this kind of report of self-assessment of how they align to these measures, then they submit for review, and they can receive an RFI, or Research Fairness Initiative certification, which I think is going to promote, or is promoting, commitment towards fairness in research and innovation collaboration. So this movement is happening, and it's important to understand it. So here is, it's quite busy slide, but I'm summarizing quite the 15 components or measures and conditions that promote fairness that are included in the Research Fairness Initiative kind of tool. The first 5, they divided into five categories. The first 5 are on fairness of opportunity. That's before your research starts. So there should be fairness before the research starts. Then others, the next 5 are in line with fair processes, and that is during the research implementation. And the last 5 have to do with fair benefit sharing. That's after the research. So we look at those 3 stages of a research project. And at all those times, there are things we need to evaluate to be sure that there is fairness. Before the research, we talk about relevance to communities. Any research done should be assessed for relevance to the community where the study is going to be done. Early engagement of all partners, there should be that buy-in and participation. Making contributions of all partners expressed, there should be, that kind of participation by every partner, and their contribution should be really, really clear and appreciated. And there's also ensuring that matching and other co-financing mechanisms do not undermine opportunities for fair participation of all partners. As I said, at budgetary level, things can go wrong and unfairness can be conceived right from there. And recognition of unequal research management capabilities between partners and providing for appropriate corrective measures. So again, what we talked about, that, different institutions, if they are partnering, one in low-income country, another is high-income country, they have different policies, and the level of development of those policies are different. So someone should not just take advantage, but we need to see, that there is a balance. There's a balance, and that where there are gaps, there are some corrective measures instead of being taken advantage of. And during the process of implementing research, we also need to look at minimizing negative impact of research programs on health and other systems. So that is very important. Patients should not be diverted, or human resource should not be diverted from giving the routine health care to doing that kind of research. It can definitely impact that, and that's unfair to the community. And fair local hiring, training, and sourcing. So think about staff consumables. Where are they purchased? Does all the money go back to the high-income country, or even when there are products which are good in the local setting, the training, the hiring process, all this should be looked at. And as I said, it affects both sides. Even those in the low-income countries should make sure that this process runs properly. And the 8th measure is respect for authority of local ethics review system. So there shouldn't be a scenario of trying to hijack or override the ethics or the regulatory framework within the local context, because that can discredit the collaborating partner in that country. And data ownership, storage, access, and use, all those should be discussed during and after research. And encourage full cost recovery, budgeting, and compensation of all partners. So that's really important. And if the study has faced difficulties like what we had in COVID-19, and there was a lot of, halting of research projects, while keeping the human resource, so which demanded an extension of most of the projects. So that brings in another cost beyond what may have been discussed before. And being able to meet that cost is very important. It can keep the harmony within a research partnership. And after research, we think about fair benefit sharing kind of measures. And one is research system capacities. Research system capacities, how have you improved? How are you gonna improve? How are you leaving the partnership, your partners? Have you made them better, and more competitive? Are they able now to take lead? So that's what we expect in terms of a global health partnership. So can now the local investigator be able to take lead, and then you work together and you collaborate? So then intellectual property rights and technology transfer, these become also issues. If a research gives birth to these, then how is the benefit? How is the sharing? As the partnership goes beyond up to that point? And innovation system capacities. Yeah, there should be measures to optimize localization of spin-offs, economic activities, scaling ability and culture of innovation. So all these, and then due diligence efforts, like minimizing negative environment, social and cultural impact, where the study is done. All that is very important, and expectation of all partners to adhere to best practice standard in research collaboration. So all that should be in place. So those are the 15 measures that the Research Fairness Initiative redeveloped, and which are reported on by different institutions that have really taken up this agenda and show commitment. So in this regard, what is the way forward in addressing unfairness in global health research? I've mentioned some already, but just to summarize quickly, one is that we need to have an increased scrutiny for fairness in research partnerships by global health research community. So each one of us involved in global health research should really think about these issues, but also the research ethics committees and the regulatory bodies should really scrutinize, the research projects that are done in partnership to ensure that the issues of fairness are maintained or addressed. And new drug trials, if new drug trials are being done in low-income countries, they should be done with the highest standards of scientific and ethical integrity, and with use of the right control arm, and with potential to offer significant value to the patients in the local region. So that's super important. And then we need to advocate for long-term commitment. For example, from pharmaceutical companies or manufacturers, to continue, allowing access by the local population to maybe a drug or an intervention that has been very useful. And early engagement of local health policymakers to ensure that treatment will be sustainable and affordable, even after a research has been done. And then research funders to increase opportunities for research led by investigators in Africa or low-income countries. So there should be a bit of that too, so that some research that really would benefit the local communities is also funded and given an opportunity to produce its fruit. And increased opportunities for research and funding and publication and access to scholarly databases for African investigators, as I said, and wide sensitization and advocacy for equity, fairness. Everyone needs to really talk about equity and talk about fairness in global health research partnerships, and embracing the efforts towards promotion of fairness. As I said, the Research Fairness Initiative is one of them that is really pushing this agenda, and to be great that different institutions embrace this movement and participate. And it is finally, as I come to the end, it is everyone's responsibility to promote fairness in global health research partnership at your level of engagement, always focus on promoting fairness. And together we can. Together we can. I want to thank you for listening to me.